Lynn Gillam is an experienced clinical ethicist, originally trained in philosophy and bioethics. Lynn is an academic director of the Children's Bioethics Centre at the Royal Children's Hospital in Melbourne. She is also Professor in Health Ethics at the University of Melbourne in the Melbourne School of Population and Global Health. Welcome, thank you.
Thank you, Karen.
Oops. Put the switch up.
Are we in business? Yes, we are. Okay, I need to get the little zapper thing, and then I'm not going to stand behind the lectern because I get separation anxiety. I need to be near you. Okay, so this should make it go forwards. Yes, it does. Great. And that makes it go back. All right, here's my topic, ethics of medical care for ICU patients. Man, there's heaps of people. There's a couple of seats down the front. Ethics is about talking together and thinking things through to figure out what the ethical challenge is, refer to a set of basic ethical principles, and then try and use those to work out in a particular situation what's ethically appropriate or not. So what I'm going to do now is quickly sketch out some ethical principles for you. With thanks to David Bowie. Anyone recognise those words? Do good things, don't do bad things. Do what the patient or the family wants and don't do what the patient and family don't want. And don't block beds. Yeah? Okay. So that's it. Simple. Last slide. Do you have any questions or can we go home now? Any questions? Now, I've put you on the spot, haven't I? How about I suggest some questions? Is it ever ethical to withdraw ventilation against the family's wishes? Can I have a show of hands? I'm not asking... you're going to answer the question, aren't you? See? You leaped in ahead. If you watch quiz shows, you know, wait till the end of the question. Can I ask you, is that a question you've encountered? Have you encountered that question? So that's quite a few. Now you can tell me the answer. Do you think it is ever ethically justifiable to withdraw ventilation against a family's wishes? Well, we're pretty sure about that one. Excellent. All right, let's keep going. What's next? Oh, wasn't meant to do that. Second one. Does an NFR order ethically require patient or family consent? Is that a question you've wondered about? Do you have to have consent for a not for resuscitation order? Who's wondered about that? Not so many. All right, so tell me the answer. Do you always have to have consent for a not for resuscitation order? You don't. Interesting. All righty, we might come back and see why. What about you've got a patient who has an advanced care directive? Now, I realise we come from different states and the law will be slightly different in every state. But if you've got a patient who's written down, I don't want any life support, and then they turn up through emergency and they need ventilation for a short term for something that's entirely recoverable, but they've written down, I don't want any life support, can you intubate them? Is it ethically acceptable to intubate them? It is. Against their clear written wishes. Wow. All right. I'm going to come back to you and find out how precise I would need to be in my written directive before you didn't intubate me. And let's go back to the other end. When is it ethically justifiable to refuse admission to intensive care, to say, no, you can't even come in? Is that a question that you wonder about? Who wonders about that? Yeah, all righty. Okay. Now, so you're actually more sure than I thought. Let's go back up to the top. So it is ethical to withdraw ventilation against families' wishes. Sorry, I'm assuming the patient's going to die as a result of this. Were you assuming that? Yep. All right. So would someone like to tell me in what sort of circumstances you would think that would be ethical to do? Any suggestions? Yep. Someone said the F word. I nearly had a no F word slide and then I thought, no, I won't do that. Because the treatment's futile. Now, I'm not going to interrogate you, I'm going to ask some of your colleagues to help. What does it mean to say treatment's futile? Ventilation isn't a treatment for dying, according to you. So I'm the family member, and you're going to say to me, continuing to ventilate your mother is futile. You wouldn't say that to me. All right. What would you say to me? Yep. Right. Okay. Now, I have to tell you, using the F word is naughty. Let's try and dig out what you actually mean. Ventilation is not futile, is it? Ever, almost. Because what's the purpose of ventilation? What does it do physiologically? Sorry? Yes. Now, you could keep doing that to me for a very long time, couldn't you? And it would keep working. Yeah? So it's not physiologically futile. So when you say it's futile, what do you actually mean? Any thoughts? Sorry? There's no hope of recovery. So if the goal is recovery, then it's futile in relation to that goal. Now, for my mother, is my goal recovery? Might be. Might not be. Might be my goal is to keep my mother alive as long as possible. And if she's living on a ventilator in intensive care, that's alive, and that's good enough for me. And I might even tell you that's good enough for her. If she's already... so can you withdraw ventilation on someone who's already dead? Yeah? Are we on safe grounds there? I reckon there is to some. I reckon... Okay, that's really important. There are always some wrong answers. You can't come and stab my mother. Even if you want to withdraw ventilation, you cannot come and stab her. If she's dead, you mean she's been diagnosed dead by brain death criteria, then can you withdraw ventilation when I say no? Yep. Yep. Yeah, you gave me... Right. Yep. So you actually gave me quite a long justification for that. I thought you were just going to say, yes, of course. Is it yes, of course? If someone's actually been diagnosed as brain dead and the family say, I don't believe that she's dead, keep going. Yep. She's dead. If you've diagnosed as brain dead, she's dead. So, yes, it's ethical. I think you might say you would prefer not to remove ventilation or cease ventilation without the family's wishes, but that's just being nice to the family, isn't it? Yeah? Sorry? Yes, and certainly in my hospital we've had a couple of instances in that, including one where a patient was actually transferred by plane back to another country to continue ventilation because brain death was not recognised in that country as a criterion for death. What do you think about that? That's happened too? Is that bad? So does that go against our principle of don't do bad things? Who's it bad for? Excuse me, the patient's dead. The patient is dead. Can you do something bad to someone after they're dead? It's bad for whose budget? So this was coming back to your point, I think is where you were going. So we've only got limited number of beds, and here we've got a dead person and we've got another living person who could make use of that bed to stay alive even a little bit longer. So that's a kind of distributive justice or resource allocation question, isn't it? Now, when the family from another country charters a private jet to send their brain-dead child to another country, back to their home country, is that a problem for us? Yes. Is it? Why is it a problem for us? Yes. Let me think about the stress. Got a comment back here and then here. Right. So if it's this came to my question, what's stressful about it? If you believe the patient is dead, then you can't do them any harm, I think. I certainly think you shouldn't spend money prolonging their state. Yeah, yep. All right, two different views, yes.
Someone actually, the patient was brain dead and the family went to court and got a court order against us withdrawing treatment until the court appointed someone to come and assess the patient, an independent
Right.
neurosurgeon to come and...
Okay.
But then they didn't
So that
go
was...
back, so then they went to the Supreme Court
Yes, yep.
and got another one.
And in the end, what happened? Yeah, so that was... Right, that's quite a long time. Can I talk to you afterwards and get some more information about that? I'd really be interested to know about that. So, yes.
I've been in a reverse situation where a close friend, family member was in another country, brain dead,
Yep.
and they wouldn't withdraw treatment.
Ah,
They were here.
that's interesting.
Negotiate that on the phone. So some of it's really culturally specific and perspective. We think that's wrong. They were right. We're qualified that we were asking for treatment to be withdrawn.
Isn't that interesting?
Really interesting.
Yeah.
We've got a strong feeling. They had a strong feeling, and culturally it's just really different.
Yep. And so in both cases, we're grappling with the don't do bad things and thinking about, well, if someone's dead, you can't actually do something bad to them. However, you could certainly do something that the family don't want. And if you're keeping your patient in intensive care whilst they're dead, and actually we do that, don't we? When do we keep patients in intensive care when they're dead? Yes. So is that okay? Even when you've got your young man at the door waiting to come in? You've got an end point, which is it's fairly soon. Other people's lives. Okay. Right. And that's what the family wants. Yeah. How are we going on time, folks?
4 minutes if you want questions.
This is questions.
We've got probably
7 minutes. Excellent. Alrighty. So, I want to spend 2 more minutes on it's stressful for staff to keep the dead person alive and send them back to whatever country versus we should respect the family's cultural beliefs. So is the stressfulness to staff enough reason to say, no, we won't cooperate in putting your family member, whom we believe to be dead, on a plane to be dead in another country? No? Who's not sure? Yes? So we see it as futile. And this is a good question. What's bad about futile? Apart from the fact that it's a naughty word and we can't say it. What's bad? It's pointless. Yes. Yes, yes. Yep. Yep. We still do it. Yep. Yep. And to whom? Yeah.
And that's not just the patient, it's the patient's significant others. So what is the overriding beneficence of a particular act that will be considered? That may not always be in accordance with what you think is...
Yes. Okay, so nicely said. When we think about what accounts as good things and bad things, that's to some extent at least subjective, isn't it? Yeah? So the family who believes that their family member is not dead and you're saying we're going to cease ventilation, they think you're about to do something that's really bad. If you think you're about to do something that's futile but can't harm the patient and they think that you're going to kill them, the stakes are pretty high for them. So you could, in fact, have a view that what they want is futile, in your view, but is not going to cause harm. So the only to the patient who's dead, the only harm that's to be done is to other patients who are going to miss out on the resources. So if they're dead through 3 court challenges in intensive care for a week, then other patients are missing out. Yeah. But if they're on the plane tomorrow, other patients are not missing out as much. So the thing that's malleable there is the reaction of you, those people involved in doing this. It's stressful if you think you're doing the wrong thing. Is that fair? No, but you might have to do it. You've just said something really important. Okay, you might not make the final decision, but you, as a moral agent, have as much ethical say in the matter and as right to an ethical view as anybody else. And not only do you have a right to that view, but you should have a method of putting forward that view so that there is a discussion. And if you have a really strong conscientious objection, in the end you should have a choice about whether to do it or not. Wow, I didn't think we'd be talking about dead patients, but that's all right. Let's go forward again. I should carry this around, but it's too big. Okay, right. So why doesn't the NFR order need consent? Any doctors in the room? Yep, doctors. When you were junior doctors, can you remember back that far? Shall I ask someone else then? This bloke over here looks a bit younger than you. When you were... Him? Yeah. Yeah?
That's fine.
Conceded, thank you. Right. Did you get sent off to get NFR orders consigned, get the family to consent to NFR? Yes, yep. And then you got sent in to negotiate? Right. So if you went to do it, that suggests that someone thinks that the family should agree. Otherwise, why did you go and ask them? Or did you tell them? Ah, okay. Right. Right. Okay. So, thank you for that description of what you did, and that's raised a couple of really interesting questions. One is are you asking or telling? And you described yourself as asking. So when there's a discussion about for not resuscitation with a patient or a family, do you take yourselves to be asking or to be telling? Yep. So you have an opinion about what you want them to say, but you also want them to make their own informed choice. Choice? Right. Okay, so this is shared decision making. All right, let's hear from a couple of other people. Ask or tell, is it a choice? Yes. Yes? Right. And if they don't? So you do think you need their consent? Right. Okay, interesting. Any other thoughts? You mean it depends what the person is not for? Yeah. So the question I'm trying to ask is, what are they choices, or is this a medical recommendation, or is this in fact a medical ruling? So a couple more comments and we probably need to finish up down here.
I think we're missing the point completely, because the point is about aligning goals of care.
Yep.
And being very clear about, if you're saying not for resuscitation, exactly what that actually means, because there's a very big difference in understanding of what you're meaning when you say you're going to resuscitate. So I think that actually going against what a family wants, unless you're very specific about what it is you're not doing,
Yep.
I think you always have to get family consent, or you have to get assent, where they have to be in line. You say, this is what is happening out, and this is why we need to do this together.
Mm-hmm.
But you're doing it together, so it's not actually a consent where you're meeting it. This is creating loggerheads, and we're missing the point, and that's why you run into the issue.
So you would keep discussing until you had agreement?
Until we had assent, and that we aligned our goals of care and saying, what are we actually aiming for, and how are we going to get there? And the reason that resuscitation won't be helpful is it won't work.
Won't work, yeah.
And so you're explaining rather than just, I want to do this, you have to agree with me.
Yep.
You're actually not
Yep.
actually
So you're trying to say we've got the same goal, and what we're disagreeing about is the method of getting there.
our goals and values. It's not about the
Alrighty, I'm going to make one final comment about that when we finish up. Now, was there someone over here? The time. Yep, last one.
I just wanted to say I agree with my colleagues. Like that's my approach too. So I always, try to reach an agreement with the family. But I always find it funny that surgeons can decide who's eligible for a surgery or not.
Yep.
And an oncologist can decide who's eligible for cancer treatment or not. But we're not entitled to decide who's eligible for an NFR.
Yeah, thank you. That is a great point to finish on. The curious thing about not for resuscitation and thinking that consent is required is this is the consent or assent agreement to not doing something. In general, in absolutely every other area of medicine, I can't get a heart transplant because I want one. And if you say no heart transplant, you don't need me to agree to that. And the same with many other things. So the resuscitation thing fits in a very odd, ethically odd place, I think. And it's interesting to think about why we think that's the one where people should agree. You have to need their consent before you not do something to them. Yeah, and that makes us wonder about ECMO and VAD and various other things that might be heading in the CPR direction. But it is now time for me to stop. Thank you very much for talking with me.